Thank you for this opportunity to talk about population-based management teams and how we can use these for future pandemics and this one and other public health crises, really to help society continue to function during a pandemic and also any disaster scenario. But before I get going, I need to acknowledge Professor Frederick Burkle, or Skip Burkle, as most of you would know him. He's the architect behind this type of concept, and we'll talk about it in detail. There were two papers here that Skip, myself and colleagues published around how this system could work. So we'll be talking about this framework and moving this forward and looking at how we can actually move forward and implement it. But just to set the scene, I wanted to go through the key points. I'll talk also to setting the background, the public health approach to pandemics and disasters. So what it means to look at it from a public health perspective. Then we'll talk about population-based management teams and how they can work. And then we'll talk about the way forward and then close out with some questions on what we think would be the best way to move forward. So the key points are, globally, everything needs to change and not in a piecemeal fashion. We can see what's happened with the pandemic around the world. We need to come up with systems that we can have better data coming in. So you've got data-driven decisions that are made in timely manners that reflect the whole of society needs. And I'll talk more about that. So that's everyone's needs in society to function. So this type of framework for global public health is long overdue. As Professor Burkle would often say, we've internationalized transport or travel, economics, but we haven't quite got there in public health. So what we're proposing is we need to get behind the World Health Organization and existing mechanisms and bolster those, use existing structures we've got, but have them in a manner that's a command and control manner, which I'll talk about as we get towards the end of this presentation. It would require newly trained population-based managers. They'd need to have operational homes, for example, in CDCs, or Centers for Disease Control and Prevention, really representing each country equally and coordinated by the WHO. So under this framework, it's thinking about a public health system that's global. So you'd have WHO as the lead, and then you've got the CDCs working in on what's going on. Can also help tailor responses and share findings a lot quicker. They'd have the responsibility to gather data daily, what could be immediately used for the population affected by the crises. And I'll talk about a local case study, a local example I was part of during the COVID pandemic where I am. And between crises, they'll use the database to improve public health response capacity. So data is really the lifeblood of pandemic management. So that's the key aspect, is data is key. That's what we've used here locally to guide our decisions. It's all about the data. Required data would be continually gathered and stored in this database, be controlled, and they would be in charge when the pandemic occurs. So what we'd be looking at is you'd have representatives from all different aspects of society, part of these teams, and they would be guiding the response that best represents the values within that local community or that region. So the public health approach to pandemics and disasters, just to set the scene, we can see systems are involved in a pandemic. And one way I like to look at it is, if you think of a forest, you can see the ecosystem there, and we need to have good biodiversity for the forest to thrive and survive. Where if we focus in on the individual trees, we won't be able to allow the forest to survive. And that's what this is really about, is providing a systems of systems thinking approach. So this could be focusing on energy, telecommunications, water and sanitation, supply chain, news and social media, social systems. So you're considering all these different impacts and considerations before, during, and after a pandemic or any disaster. And one key thing in public health is the social determinants of health. So the needs for the social determinants of health do not stop during a pandemic or a disaster. The role of the population-based management teams would be to make sure that we can still achieve the social determinants of health, because there's a few things we know about pandemics, their duration and factors. So we need to make sure that we can maintain agriculture and food production, education, because we don't want people to miss out on a year's worth of education, for example, or 2 years. People need to work. We need good living and working conditions. So these are all the different factors, and housing as well is a big area too. So what we need to remember, or what we think of from a public health perspective, is the impact on the entire population of all diseases, not just one, of all, and we're thinking about the social determinants of health. And this is some work that I did with colleagues that we try to analyse the potential impacts of prolonged lockdowns, particularly for COVID. So you can see that you've got the Maslow hierarchy of needs, and you overlay the social determinants of health, which is a big factor in public health, because we're thinking about all of society and the impacts on the whole of society. And these were some of the impacts we thought. So for example, safety needs, we thought that increased unemployment, could be reduced access to resources, individual stability may be impacted, maybe it could result in some security issues, and things like that is what we really were looking at. So we went through the Maslow hierarchy of needs, overlaid the social determinants of health, and try to examine what would be the possible impacts. What we do know about pandemics, that there are phases. So there's the interpandemic phase, there's the alert phase, pandemic phase, which we're in, and some parts of the world are starting to go into this transition phase. So these are things that we know that occur in pandemics. If we look back at history, this is how they historically play out. We need to get to somehow that herd immunity point of maybe 70 to 85%. So that's how pandemics have historically played out. It's just how do you get there? So this is where we're going to have preparedness, response, recovery, and then you move back into preparedness. And the reason I keep talking about this whole of society approach is we need to think about all diseases at all times. Doesn't matter what the crisis is, people are still going to need TB treatment and malaria treatment. So we can see here the Global Preparedness Monitoring Board. This is a report that they produced analysing some of the potential consequences of the way we were collectively responding to COVID, and really focusing in on the COVID-19 pandemic and not continuing other treatment, care and services, which you could argue on this modelling had led to potentially 1.4 million preventable deaths in 2020. So you can see this due to malaria because treatment, care and equipment wasn't provided, same with TB and AIDS. So all these conditions continue. People still need to receive their cancer treatments, for example. So the idea is the next pandemic, we can use population-based management teams that reflect all aspects of society to ensure that we can maintain treatment and care for all diseases and prevent those preventable deaths. So that's one of the big lessons. You can also see here that there can be mothers that increase deaths of mothers and children because, again, basic interventions aren't being followed. So this is due to a disruption in basic interventions. And if you think back to the social determinants of health, you can see some of the flow-on impacts. There may be 100 more million people going into extreme poverty, is what this report has suggested. And that's extreme poverty. So that's going to be generational impacts. In this report, they propose that border restrictions and lockdowns slowed agricultural production and increased food insecurity worldwide. So this is where we start to get population-based management teams start to think about how can we reduce the number of people that move into extreme poverty? What are the public health mitigation measures we can do to slow the spread of COVID, for example? The World Bank has estimated US 10 trillion earning loss over time for the younger generation as a result of school closures. So you can see big impacts. This is the big point for me. It would take 500 years to spend as much on investing in preparedness as the world is losing due to COVID. So investing in preparedness would have helped us in a dramatic way. And you can see here how we can start to apply mitigation measures that can allow society to continue as well. This is a really nice study, a local study in Chicago metro area, showing you that 20% maximum occupancy cut down new infections by more than 80%. So by applying this selective approach based on data and evidence, you reduce overall visits by 42%, but businesses can survive. So restaurants can still survive. And that's what I mean by a whole of society approach, that we can keep businesses going in the safest possible way. Because often the poorer are the worst affected, and we need to look after the most vulnerable, and they need access to employment, education, and all those factors, and healthcare. And 10% of places people visited accounted for 85% of the predicted infections. So you can see straight away there that if we put some restrictions on 10% of places, you can help reduce the spread in 85% of the situation. And I think this is a really good example. This was as the American football season started. This was an example. I was watching this live, and I recall the director of public health for this area coming on TV talking about their safety protocols. So that's what I mean by keeping society functioning during a pandemic. Because if you refer back to the social determinants of health, you can really see, and the Maslow hierarchy of needs, humans need interaction, they need to do things. So you develop guidelines to do things in the safest possible manner. And that's why we had crowd capacity limits and social distancing and all those factors. So I was really encouraged to see the director of public health there having the team that was overseeing this, so they could still play the football, people could still attend, so you're meeting societal needs, and it was done in the safest possible manner. Okay, so I've spoken a lot about the higher level aspects. What do the population-based management teams look like? They need to be interdisciplinary, multidisciplinary teams, led by public health that include experts from critical care, infectious disease, epidemiology, environmental health, and it would be really reflecting the current demands of the field and society served. The key factor is the society served. The team would be assisted by multidisciplinary expertise in anthropology, sociology, law, industry, and technology, because they're all members of society which we are here to serve. And health crisis management requirements should define the working relationships and make the uncomfortable decisions as well. The key factor around this is no one authority or organisation possesses all the resources and expertise required to mitigate pandemic risks. So that's what we're really highlighting, is that there's no one person or individual that knows the best way to handle things. And I'll talk about a local example here as well. We need everybody's help. And you could see that the spread of COVID-19 led to independent decision-making efforts of nations and jurisdictions within nations as well, which will have global consequences for years to come. So this is what we mean by, if you have a broader public health system approach around the world using these population-based management teams, you can have an approach that really focuses in on that sort of forest ecosystem, I guess you could say, which is really that whole of society needs. And this is what it would look like. So some parts of the world already have a lot of these models in place, but would have a global public health system and population-based management teams. So you could see, for example, you might have one per country or region. In the United States, it'd be one for the 10 HHS or CDC regions. You might have multiple population-based management teams as well. Perhaps for smaller nations or parts of the world, you might have a regional CDC. And these teams would be made up of data scientists, ecologists, public health professionals, software developers, all these different factors. And then we could be making population-based data-driven decisions. And they need to reflect community needs. Because what we're seeing a lot of this come out with the response and recovery to COVID is the need to reflect community values as well. And if you do this, follow this type of team, you can be reflecting the community values that you're serving best as well. So you could see here, this is how it could potentially work in the United States. You could have one where I am, I'm just south of Dallas. You could have one in region 6. You could go region 4, have Seattle as well. So you can see this is how it can conceptually work. There are operational imperatives. All pandemics share the following. So historically, there's been pandemics. So we've got history to look back upon. All individuals either have the disease or susceptible, all require healthcare needs at some points, all require intervention, or pandemics may require sustained public health operational response lasting 12 to 24 months. And one of the key factors, if you apply public health principles and also emergency management principles, as you enter a pandemic, whatever interventions you bring in, you need to have your exit strategy planned and ready to be executed. Because without an exit strategy, it's really hard to leave the disaster response and move into recovery. The cornerstones are working models in three major technical domains of pandemics. These are the key domains: how the virus spreads, so the incubation period, reproduction ratio, mitigation measure effectiveness. These were all things we were doing here locally where I live to go work through the pandemic. Resource management and decision models as well, providing epidemic data and resources. So you want to capture management awareness, thresholds. So you want to understand thresholds. And one example I'll use in Texas, just because I'm familiar with what happened here, there were different thresholds used to guide different restrictions at the peak of the pandemic, and surge teams were also moved around the state as some hospital capacities became tighter. So you can develop these types of thresholds. And then you can have a compartmental model used to commute the infected population and the number of casualties as well. So now we've got so much data, we know the consequences of COVID and what the risk factors are and who the most vulnerable are. So we've now got a lot of this in place now with COVID. So the core databases. So we want background information. So we want to understand the affected population pre-pandemic. So this is the demography, access to essential services, the health status, also socioeconomic status. So what we've seen here as well with COVID, and we'll see it in other pandemics when they occur in the future, is those areas where the social determinants of health are not achieved, they've been most severely impacted. They're often the most vulnerable populations. So we've got clinical, case, and virological data as well. So this is case definitions, identification, outcomes. So you could be looking at case fatality rates because infection fatality rates are a lot harder to work out, particularly early on in a pandemic, death rates and time course to death. And we'd be looking at public health control measures. So contact tracing, quarantine measures, travel restrictions, and a big thing is your epidemic modeling. So to work out what would occur if you do certain measures and don't do others. And this is the data that you'd be identifying pre-pandemic. So the population-based management team, so if you think where I am in this region, where I am in the United States, you'd be doing it for the population at risk. So you'd be looking at the age group. We know through COVID that the people most likely to have severe and bad outcomes are those that are older. So as you get older, it increases, as well as if you've got underlying health conditions as well. So we know those factors, and that would be for most pandemics or most respiratory diseases or disease outbreaks as well. So understanding your population at risk. Settlements, so you want to know community size, what's the capacity, what's the ability to deal with what was occurring. And locally here, I was amazed by our ability to go through the worst aspects of COVID and our health system continue without the need to open up alternate care sites. It got borderline, but it was the health system here where I am in Central Texas was able to withstand the worst of it, which I was very impressed because of the time that people had to prepare based on other lessons in other parts of the world. Access to essential services as well. So do people have water, electricity, all those different factors. You also want to know the health status, so maybe some vaccination rates as well, nutritional status. You want to know what the endemic diseases are. Chronic illnesses are becoming more important, and this is something Professor Berkler and I have spoken about in disasters as well as pandemics. We're seeing the most vulnerable are those with chronic illnesses and conditions. So if we invested in implementing the social determinants of health and enhance the health and well-being of a community, the impacts of a pandemic would be naturally less because you'd have a healthier community. Also infectious diseases, what's the rate of HIV, TB, and other major diseases. And then you'd also want to be looking at the macroeconomic status, labour force occupations, unemployment, also literacy, so you can work out your communication methods as well. So clinical case and virological data. So this is where we'd be looking at case definition, suspected, probable, confirmed. You'd be going through, do we have severe cases, ICU cases? So this is where you start to move into using hospital scenarios or capacity to guide your interventions, which seems to be the model that most places around the world are starting to go to guide the measures that are in place for COVID. So you'd be looking at age, gender, comorbidities, cause of death. So you want to understand the population at risk so you can protect those most at risk. Virological data as well. Maybe you'll do some sentinel site testing, which we did that here at Baylor University. And we did rapid contact tracing. I'll talk about that example as well shortly, how we applied these principles and practices. And then maybe there's also some sensitivity testing as well. And then when you go to the modeling, control measures and impact, you want to do epidemic modeling data. So population sizes, groups most at risk. You want to look at epidemic curves. So you can look historically at pandemics as well, globally, how the epidemic curves have played out over time as well. You want to understand economic data, displacements, evictions, business closures, all those types of things as well. If you're going to do a lockdown, you want to know the duration and what's acceptable for your society to continue functioning. And at what point do you need to move on to make sure you can continue treatment and care for all diseases rather than focusing on the one. There are other technologies out there. So there's infection screening already, that's already out there. Contact tracing, we've got those skills out there. So this is just bringing everything together. Quarantine and isolation, we've got ways or novel ways you can do that. Medical logistics as well. And we've got pandemic tracking, so tracking a pandemic, and clinical management as well. So working out how you'll do things. So maybe lab testing, pooling, telemedicine, and video conferencing, for example. So this is just a local case study. Here at Baylor University, I was asked in May 2020 to work out how can we reopen or get open for the full academic year, which we successfully did. One of the first people I called was Professor Burkle, and he said, set up a population-based management team to guide how things go. So I spoke about whole of society needs. This is an example of a whole of society need being fulfilled. The local community here in Waco wanted Baylor University open and needed it to be open because it's the major employer in the area. So we were tasked with a whole of society need. So we engaged, when we got this task, the population-based management team, engaged the local health services, emergency management. And really the goal was to help students, staff, faculty, contractors navigate the challenges. We established, again, the multidisciplinary teams. So we had every recommendation we had based on these population-based management teams and public health principles and practices that have been around for hundreds of years were implemented and followed. So we had health protocols, so face covering, social distancing, compliance monitoring. I was teaching in person. We had other people teaching in person. So students were in the classroom. Some could go online if they wanted to, but predominantly we had in-person available, and we were using face coverings because we know they work. As a result, in-person operations have been sustained, or they were sustained from August 1 right through the whole academic year. And the success for us now is we've got very high enrollment numbers, and we're planning a normal operations in the fall. Well, we're operating as normal now. So you can see here, through the worst of the pandemic, we had testing, surveillance, tracing, isolation, and quarantine. That got us through. And the actual COVID case numbers we had here at Baylor University was about 3 times less than what was happening in the broader community. And some of our discussions as well moving forward is we were using data to drive the decisions, and looking at it, we thought these were college-age students, and wherever they are, because they're humans, they're likely to get COVID in whichever community they are. And if they're here, they're less likely to pass it on to family members who are most at risk of COVID. So we had some really good lessons as this went through. We had clinicians, we had the whole realm of population-based management teams around. And I'll show you what the team looked like. the team, we had everything that Professor Burkle had spoken about, and then the measures we had were testing. We had pre-arrival, surveillance, our contact tracing capabilities. We went double the recommended contact tracing capability. So at one point here, the recommendation was 1 to 1,000 in your community. We had one contact tracer for 400 people. So the idea was, as soon as someone tested positive, they were traced and isolated, and all their contacts were quarantined as well within a 12-hour period. It was done as fast as we could physically do it. Again, following public health principles and practices that have worked. We provided accommodation for people that were isolated, as well as healthcare. We had a live dashboard going, so situational awareness. We're looking at trends. We were taking a very targeted approach as well. Again, face covering, social distancing. We had all those factors in place as well. And we created our own testing capacity on campus as well. So we have PCR testing capability, where during the spring, we had every member of our community tested every week, and the results were same day. So that meant that the results came in, and we had a contact tracing team that was available all the time, so we could immediately trace and isolate whoever needed to be isolated and quarantined. So that was really the backbone of our operations, to keep and sustain our operations to meet that whole of society need that we had here in Waco. So this is what our dashboard looked like. So this was publicly available. So you can see here, we did the testing and pre-arrival. So you can see the peak there. As most of you that work in mass gatherings or something along those lines, where you get a group of people together for a period of time, the first few weeks, you naturally have an increase in respiratory type illnesses and other diseases. So we expected that. And then we can see we had spikes. This was after Halloween in the United States. We had a little spike there. But none of these spikes were consistent with what happened in the broader community. So talking with the local health leaders here and community members, looking through the data, there was no relationship between cases on campus within the Baylor community and the broader community. And that was one of our major concerns, was potential spillover in a very vulnerable population. We managed to avoid that from occurring. So that was just a local example where we were tasked to stay open or open and continue pushing through using public health measures. And using these population-based management teams, we're able to keep the university sustaining, operating, and meeting stakeholder needs as well, and student needs. And one factor that we didn't consider when I've spoken to colleagues is, they said if you weren't open, that would reduce your graduates potentially in 1 year, which could result in workforce shortages. So in a broader contribution to our community and other parts of the country and world, we have people that have graduated and can now fulfill jobs where there are vacancies now. Priorities for hospitals and public health systems. So I've got a very local example, and you can easily scale that up. So we want to improve capabilities and capacities in surveillance and discovery at the local level. It's all about the local level. Develop triage and management systems with clear lines of authority based on public health, epidemiologic requirements, capability, and capacity. So you'd have these teams that link to local surveillance systems as well. And you'd also need to establish operational priorities. As I mentioned earlier about the preventable deaths, we want to be able to prevent those preventable deaths and ensure we've got our operational priorities in line so we can do that. So this would be using a triage and management system that reflects the population at risk. So focusing in on that population at risk, and that's what we know about COVID. We know the population at risk. We've got vaccines that can eliminate the risk, but we know those who are most at risk. And you want to develop organizational capacity that uses lateral decision-making. So on this team that we had clinicians that have had local, national and global experience working in different disease outbreaks. So we're very fortunate to have that. We had people that would provide meals to students and provide entertainment for students, right down to our athletics department. So we had all the different aspects of the population, and we guided decisions to make sure we also met, for example, the mental health needs of students, staff, and everybody else as well. And then when we look at the standards of care, it should be set at the local to federal levels and spelled out in existing incident management system protocols as well. See, there's already been a little bit of a move towards this direction. So you can see WHO in partnership in Germany has launched a new global hub for pandemic and epidemic intelligence. So this is starting to gain some traction. It's just how do we get a clear command and control structure that also takes the pressure out of frontline clinicians that are providing treatment and care to people so they can stay focused and other health professionals can keep doing that. So you have these population-based management teams that come in and rally behind that and support that, and then the decisions are made to make sure society can continue functioning. So key points. Globally, as we've seen, everything needs to change and not in a piecemeal fashion. There was a framework for global public health, which has been described and it's long overdue. The WHO needs to complete control, totally independent and well-funded as well. We need newly trained population-based managers. So they need operational homes, for example, in CDCs. And data is the real lifeblood of pandemic management. We need data-driven decisions. And the strength, if we apply this approach of population-based management, is you've got all aspects of society engaged, so it gets very hard for political intervention as well, because then you're reflecting what the goals are for the society, not a certain group, but you're looking at what that community needs. And so we need data to be continually gathered. We need data to be controlled by the teams and assigned to global CDCs. And they need to be in charge once a pandemic occurs and boosted by relationships that they have with multiple healthcare providers in their area of responsibility. So on that note, I'd like to open up for questions and comments.
Okay, can you hear me, Ben?
I can hear you. Yes, Andrew.
Great. All right, well, thank you so much for that presentation. I think it was really, really interesting in presenting the concept and some of the research that went into it. We have several questions that have come in during the presentation. And so I'm going to read one of them first to start out with, and then I'm giving Paul Barak a heads up because he has a multi-faceted question, and I encouraged him to ask you directly since it'd be easier than me reading it. But we'll start out with a question, a comment and a question from David Hogan. And David says, these are excellent principles that should have been implemented ages ago. We sort of started with the H1N1 pandemic. Obviously, implementation requires involvement of policymakers locally and nationally. Other than publishing, writing, education, and lobbying, do you have any suggestions or experience in getting this message across to policymakers?
That's a very good question. How do we get it to policymakers? And that's something we need to collectively think about. How do we get there? One aspect that, and this is one of the projects I'm involved in, is there's a tool called the Public Health System Resilience Scorecard, which engages this sort of population-based approach. And by applying that through, let's say, your emergency management office, because each local county or local government, there's an emergency management office and it's under law as well that they need to do certain things. I've seen that type of approach be used where you go through this scorecard process where you bring everybody in, and I've worked with the UN Office for Disaster Risk Reduction on this previously, and it's adopting that model. And what you do is you get all the stakeholders together going through your scorecard to work out the resilience of your system. So I spoke about how here in Central Texas, we're very fortunate to be able to absorb the surge in COVID cases. Not many parts of the world can do that. But what you can do is you can look at the resilience scorecard to identify key indicators of weakness or areas for improvement, present that as action items and recommendations from the county, for example, through the emergency management to the county officials. And then that's starting to get some accountability that we highlighted these as at-risk areas. And the parts of the world where we've applied that more broadly for disaster resilience, you seem to get a lot of buy-in because the politicians are then seeing all the different members of society highlight 3 to 5 areas of vulnerability and understand if they fail, we could be in trouble. And one example of where we applied that type of approach was when I was working in Australia. one of the most vulnerable locations we identified for our hospital was a sewage pump station that we would not have identified, because if that backs up, you lose your hospital. But we weren't thinking of that as being one of our main vulnerabilities. So you could have, for example, an action item to improve that. Or maybe you go, we've got roads that will flood and we need to get our logistics and distribution up. So I think really from the ground up, and it has to be that ground up type approach, I think is the best way to go about it, and using these population-based management teams. And it's, I guess, also workshopping, how do we influence the policymakers to understand that, look, if we'd invested in preparedness, we would have saved a lot of money and lives.
Great, thank you for that, Ben. And David just answered. Thanks, Benjamin. Helpful answer. Paul, I'm going to unmute your microphone here.
Can you hear me, Andrew?
Yes. Yes. Paul has a couple questions related to the population-based management team. So I encouraged him during the presentation through the chat to ask you directly. And Patricia, I got your message and you're on deck, so I will we'll get to your question after Paul here.
Hi, Ben. Thanks for your comments. So my team's been involved for many years in developing team training programs like Team Steps that you may be familiar with. The real question that's begged from your very interesting model of PBM is to really go down to the details. How would you train them? What would be their competencies? What would be the leadership and governance? Because we know that these types of teams struggle with authority gradients, struggle with confusion around roles and responsibilities. So in order to make this politically viable, you'd have to actually be able to demonstrate some metrics for ongoing performance and impact. So that's my first question. If you want to say a little bit more about how these teams work together, beyond identifying them theoretically, what would be the nuts and bolts about how you build their competencies up, and how would you manage their ongoing competencies in between disasters?
Thank you, Paul. That's a great question. And when I was talking to Professor Burkle about this is really about presenting a framework and a concept. Now we're up to the how do we do this? And I think your questions are exactly right. It would be training really focused in, I think, one would be emergency management and public health principles and practices. So really understanding that in any disaster, not just COVID, and I remember Professor Burkle said this to me in the Ebola outbreak as well, we need to make sure we have the resources available to continue providing treatment and care so that we don't have those preventable deaths. So I think there's a few facets. I think it's emergency management training and getting at thinking around, sort of that forest concept, not the tree concepts, and whole of society needs. And then two, it would really be training on how you use these tools, how you do the data assessment, how you do interpretation. So epidemiological training as well, and understanding how you can model. So you've got factors there. So there's some of the key training areas. And then it'd also be, how do we share the information as well? How do we get it out there and getting the communication? So there's some of the detailed areas I would think of. But Paul, I think working with people like yourself and others, working this out is what's needed to work out the how. So great question, but they would be some of the thematical areas I'd originally be thinking about. And one of the factors we would need to, this is I've worked in emergency management too, is whatever interventions or disaster you're in, at the same time, you need to plan your exit strategy. And that's something that would need to really train these people on, is to understand that even in a crisis, you need to have your exit strategy. And you could also get that through exercises. So the teams would probably also be trained in, how do you run really good public health exercises to pressure systems? And there are tools out there to do that already. So it might be a coordinating body that runs different exercises in different parts of those regions they're responsible for. Does that help, Paul?
Yeah, I think it's a good start. I mean, what we've learned from a lot of years, both in the military and civilian sector, is that unless you do this on a regular basis, all the good notions and intent are great, but the variation on the ground is extraordinary, so much so that it's hard to get the political buy-in. And so we need to be very practical about the nuts and bolts in order to make sure that we don't get big pushback from policymakers who need to fund this. And that really lends into my second question, which is what are the major barriers for setting these up? And And we need to be thinking about some standard instruments on how to, again, different community types and settings. Waco, I think, has about 150,000 people. I live in a city of 15 million. How do these things scale up? And how would you test this in a way that's, relatively rapid and not time consuming in order to justify to the local or regional authorities that the PBM model was sustainable and would align with local community needs?
Yeah, great question, Paul, as well. And I think that's part of the scalability. And when I was talking to Professor Burkle, he said, use the local example of the Baylor University, just as a local example. But I think you could scale that up. And I'll just use the example I've been thinking of here in Texas. Again, I'm very focused here because that's what I'm familiar with from the COVID response. Is the way you could be looking at it is the population-based management teams could be assessing healthcare needs, availability, where will resources be tight in this scenario, this threshold. And that's something that I think really happened here in Texas is there were surge teams, and some of the committees I was sitting in on, there ended up being a COVID surge team, and they were able to be moved around. And there was almost this population-based type team being used to guide some of those activities. So I think that's how you can start to show some of the benefits. It's also trying to think, and you raised some really good points, Paul, and this is something we'd need to talk about, is that raises the issues around the barriers as well, the political buy-in. How do we get people engaged? And one way I think is really demonstrating maybe where we can find case studies of where this type of approach may have been activated or not planned on, but was activated in the world, and where the outcomes may have been more beneficial. And then really highlighting if we can get better prepared, maybe some of those early stage issues around PPE and those types of things could be avoided as well. But Paul, these are questions that we need to answer to put this into the how. I know that I think there is some funding coming down for better pandemic preparedness, and maybe this is a way we can do that. And a concept I play with is maybe we're better off investing in the social determinants of health so that next time we get a pandemic, the community is actually healthier. And then that can reduce some of the need for the other approaches as well. So this is a discussion, Paul, I'd like to continue with you and anyone who's interested on how we do this.
Delighted to. We'll follow up. Thanks so much for those great responses, Ben.
Thanks, Paul.
Thanks, Paul. And thanks for asking the question live. We have a question from Patricia. I'm going to go and unmute her microphone. She had a question about a whole of society approach. And Mark Turner, I see your question here and your hand raised, so you'll be after Patricia. So Patricia, you there?
Yes, I am. Thank you very much. Thank you, Dr. Ryan, for your excellent presentation. However, as a former EMS director in a county local setting, I find that those who say that they use a whole society population-based disaster management approach appear to homogenize approaches in these situations. And that ends up systematically leaving out children and the disabled. How do you create incentives to address these gaps?
Great question, Patricia, and I think that's a very important area. And that's where, when I mention whole of society, I mean also the people with disabilities and children as well. And we saw some challenges there during COVID as well. And I think the way we can do that is having these teams, you can bring someone to the table. So you can have school and education representatives, people from disability sectors as well. And I think that's probably the best way we could bring this in through the population-based management teams. Or also, as you said, you worked in EMS, is really trying to get them a voice at the table. Because without their voice, we're not going to meet their needs during a crisis. And I know schools where I am, we've been open the whole time during the pandemic, and a decision I made for my children, we looked at risk profiles, and everyone else in our neighbourhood, we all send our kids to school. There were safety measures such as face coverings and all those factors, but we were thinking about their educational needs and damage that could have been done over the longer term. And I think that's having a really big voice from those most vulnerable people. And a lot of the time, it's the vulnerable people that are most severely impacted by some of the restrictions that are put in place, but they don't have the voice. So I think giving those vulnerable people an understanding or ability to have their needs met is a key factor. But again, Patricia, talking about the needs of children and people with disabilities, that's an area we really need to focus on, because you can also measure your society on how well you care for the most vulnerable as well.
Okay. Thank you.
Thank you, Patricia. These are really great questions. We have a question from Mark Turner, and I'm going to unmute Mark's microphone here. Are you there, Mark?
I am, if you can hear me.
Yes, loud and clear.
Yes, good evening from the UK. Ben, I agree with you about your thoughts of the World Health Organization being in charge of collecting the data. The problem then leads on to the implementation of what to do with it, because I suspect there will be governments who will ignore the advice or the diktats for political reasons. I mean, we've got a classic case over here, the UK versus Europe. Now that we are independent of Europe, we have been able to move a heck of a lot faster than Europe in our vaccination program. And this has resulted in a number of spats with Europe. Initially, they was threatening to withhold certain elements of the AZ vaccine produced in Europe, because supposedly AstraZeneca had reneged on contracts, later to proved wrong. We've now got a case where some European countries won't allow UK citizens into their countries if they've had certain batches of the vaccine produced in India. Nothing to do with the how the vaccine was produced. It was to do with some supposedly contractual obligations with India and Europe. How your thoughts on how could we potentially overcome these problems?
Wonderful, wonderful question, Mark. This is fantastic. You've got me rattled a little bit trying to think of the best way. And I do recall seeing those issues from a US perspective, watching the media and seeing how that was playing out. And that will be one of the challenges we'll need to think about, is how do we get vaccinations rolling out as well? And maybe a way around this is, if you can, it's not that easy, but if we could work out a way to globalize public health, like we have with economics and transport, and I know there'll always be faults here, it won't necessarily work, is maybe if we've got data-driven decisions, we can start to prioritize, for example, vaccines to different parts of the world for the most vulnerable people. That's one of the things I'm thinking about. But Mark, and like people on here, I think we really need to pull these challenges apart as we wind down from COVID to work out how do we not do this again. And I don't have any other answers other than that, Mark, just to say I think we need to explore it further. And that's something Professor Burkle and I said, we've got this concept, it's a how do we get it out there now? How do we implement it? We're starting to see some of that get a little bit of traction, but as you know, the hardest thing is actually the implementation, and that's what we've seen with the vaccine rollout in some parts of the world.
If I could actually just add another comment to that one, what probably would be extremely helpful, certainly for us over here at the moment, if there is international figures coming from internationally to show the effectiveness of the vaccines. We are having problems, strangely enough, and I know this because I volunteer in a vaccination centre. We've got the 40 plus, the vast majority of the 40 plus age group have now had their second jabs. The just under 40s are coming up to their second jabs. The problem we're having now is getting the 18 plus year olds coming for their first jabs. For some reason, they just don't seem to want to have it. So if there was international figures to say, hey, this is brilliant, it might just give them a nudge in the arm.
You're exactly right. That's a challenge we're facing here as well. We're very fortunate here, and I'm assuming the UK is, not every part of the world is, but we're having the same issue where we've got readily access to a vaccine as well. And that's where I think I keep coming back to the data-driven decisions. Is I've heard some commentary, not where I am, but other parts of the world, where people haven't had confidence in the vaccines, where all the vaccines are actually amazingly good and developed in such a short period of time. And I'm trying to understand, Mark, and maybe I'm biased, and we all are because we're in health, and disaster management is I'm still rattling my mind is why are people questioning it? I know they've got their motivations, but we're also looking at here locally providing some incentives, more incentives for people to get vaccinated. I'm not sure what incentives you're permitted to do in the UK, but that's something we're looking at is how do we get our incentives up. But interestingly, and again, just a local example, we've got orientation for our freshmen coming in on first year, and we've got vaccination rates in most of the group over 60%, which I've been really surprised about, even pushing 65% in some of the cohorts. So I don't know what the difference is, Mark. And again, this is where if you have these population-based management teams, you can have the media, not the media, but people who know how to communicate with the public. Sometimes you might use, depending where you are, faith-based organisations to do the outreach or someone they trust. So Mark, I think your international celebrities or something along that, maybe not celebrities, but using international people as well can help. So we early on here did engage faith-based organisations as well because that works well where I live to get some of the messages out. So not sure, Mark, if there's any good cricket players out there that could promote it or something along those lines, but a great point.
Thank you.
Again, thank you, Mark. Great questions here. We are coming close to the end of the hour here. I have one question that maybe we could just end with, as we don't have any more from the remote audience. And I really want to thank Paul, Patricia, and Mark for asking questions verbally. It really does help enrich the discussion. The question is, it's a very broad question, but what would pandemic resilience look like in the future?
Very good question, Andrew. What does pandemic resilience look like, or what could it look like in the future? I think what it looks like is when you come out of your pandemic or any crises, there's not generational damage done to your society is one of the key factors. And we're seeing that with that report, the global preparedness report that says that about 100 million people are moving into extreme poverty. We need to be able to respond to pandemics in a way that we can prevent that from occurring. We have the safety measures there for COVID as well. For example, face covers work, social distancing, good hygiene. We know what works. The face covers are the best line of defense. And if you're to do that, you can keep your society open as well, I would propose, if you're following that. And that would be a more balanced measure and ensure once you get to the other side of a pandemic, because pandemics aren't new. This is the fifth one in the last 100 years, is we can have an approach to a pandemic that keeps your society going, exactly like that Chicago Metro study I showed you, keeping businesses open enough so they survive to get through the pandemic. So we can get there. It's just a matter of being able to implement that. That's how I would measure resilience. So you can see many things happening around the world still continuing, and countries are doing what they can to survive. And some examples are doing sporting events, for example, maybe with lower crowd capacities and things like that. There's ways to do all this, and we've seen that demonstrated. I think the next time we face a similar pandemic, it's probably trying to get to those levels of restrictions rather than going too hard, because the pandemic will continue until 70 to 85% of people are either vaccinated or got natural immunity. So I think, Andrew, great question. I measure the resilience in that sort of forest view, thinking about what are the generational impacts, and let's not have those generational, and let's keep it short term.
Thank you for that, Ben. Well, look, we're at the end of the hour here. Thank you so much for taking the time to present and share the research from the articles that you worked on with Professor Burkle and share your insight with the remote audience here. We really do appreciate it. All of the presenters who participate in the WADM webinar series do this as volunteers, and we do really appreciate you taking the time and sharing your expertise with everyone.
Well, thank you, Andrew, and everybody's time. Feel free to reach out. I think this is an open discussion that we need to explore.
And everyone in the audience, we'll send out the links to the slides as well as the recording when they are both posted online, which hopefully I'll get to this afternoon, but definitely by tomorrow. So I suppose with that, we'll end this webinar. And again, thank you everyone for your participation and support. And thank you, Ben, for your time.
Thank you. Take care, everybody.
Bye-bye.